I'm Marilyn Priel. On this program, addictions will be discussed with prominent neuropsychiatrist, Dr. Saad Shakir. Please stay with us. Dr. Shakir is trained in many areas of medicine. He's founder and CEO of Silicon Valley TMS with multiple offices in the Bay Area. Welcome once again, Dr. Shakir. Thanks for coming back.
Thank you. It's a pleasure to be here with you.
Well, I'm happy to be talking about substance addictions. We know now that addictions are not just a matter of decadent living or weak personalities, but our brains and our chemistry have so much to do with it. Could you tell us how all that functions?
Your audience probably recognizes you have a brain specialist talking about addiction, which is very appropriate because the research indicates a strong connection with the nervous system. And substance use disorders is what we call them now, is an epidemic in this country and in the world, particularly if you look at opioids. Every single year, 56,000 people are dying of overdoses in this country. And that's probably an underestimate because some people don't get recorded as such. On the positive side, we're discovering pathways in the brain that is a common denominator. There's an area in the brain called the reward circuit of the brain, which is in the midbrain area.
So how does it come about then that one person might become addicted where someone else wouldn't, as far as the pornography or the games or the substances? What goes on in that area that would cause it to be that way?
I think that's where the research is heading, is why some people develop addiction and others don't. There's no answer, but we know genetics plays into it. Genetics is an important role. There's an indication that if there is an addiction history in the family, there is a higher rate of addiction by exposure to a substance that hits the reward center of the brain. There are also other factors. It's highly correlated with psychiatric issues in both ways. So we call that comorbidity or comorbid illnesses. For example, oftentimes people who have depression or anxiety discover addiction, a substance that makes them feel good, and they get addicted to it. We worry a lot about teenagers with ADHD. And a lot of teenagers with ADHD, their parent, first thing they'd say, oh, I don't want them to be on medication because I worry about addiction with that medication. Little do they know that the research shows if you treat appropriately ADHD, there is less likelihood for their child or young adult to go to the streets for addictive substances. Because a lot of times people seek rewards or satisfaction or immediate gratification for their emotional issues. So there's a close relationship between the two.
Well, now, from the things that I've watched on videos and television and read about, there's something called dopamine. Is it too much or not enough that affects this neurotransmitters in the brain?
That's a great question. So if you look at the reward center I talked about, and you zoom into the synapses, there are billions of neurons there. There's a heavy concentration in the reward center of dopamine cells. So basically there are different chemical messengers in the brain. We've talked previously on this show on serotonin, norepinephrine, and dopamine. So these three are associated with mood issues. Dopamine specifically is heavily localized in the reward center of the brain. And dopamine, I nickname it the pleasure neurotransmitter. So anything that stimulates dopamine release, you're likely to say, hey, this feels good, I want more. And that's essentially the basis of the problem. A lot of people who use external stimulants, for example, substance abuse, deplete the area from dopamine. So they become chronically at a risk of seeking it from drugs, street drugs, or behavioral addictions and things like that.
How do you deplete So you need a certain amount of dopamine. How does one deplete it?
Well, for example, heavy use of stimulants or hallucinogens or ecstasy there's some research on brain imaging that shows there could be cellular damage to those areas
So
of the
then
brain.
they have to take more
They have
to
to
get
take
the same
to take the same effect
rewards.
for two reasons. One is because of the depletion, but the other is the phenomenon of tolerance. So in other words, any drug that you develop tolerance for, you're at the risk of needing more and more of.
So then it's
including
a
smoking.
psychological and a physical need, is it then?
Yeah, the psychological is
addiction.
more the habit. I want to feel good, and this makes me feel good, so that's sure good. But a lot of it really is directed to the biological base, which is the dependency, the tolerance that develops with use of these substances.
Now, I want to talk about the different kind of substances.
Absolutely.
There's the stimulants and the kind of a sedative type, relaxing or calming ones,
Could I
and then
put-
the hallucinations. So could we take one and like maybe tell me about the stimulants, which ones they are? Like,
Sure.
is it like PCP and
May I step back a little bit
sure.
and see how good my memory is?
Okay.
I'm going to tell you the 10 categories that are listed as substance use disorders. Alcohol, tobacco, cannabis, caffeine, inhalants, stimulants, hallucinogens. Let's see what else.
the sedatives,
Sedatives, anxiolytic,
anti-anxiety,
and
yeah.
hypnotics, and other substances. I might have missed one there. But all of these are categorized as under the substance use disorder. So I can take any one. You mentioned.
Well, the stimulants
Stimulants.
would be, it's like PCP then,
No, PCP is classified with a hallucinogen.
hallucinogenic.
Yeah,
okay.
phencyclidine.
Okay.
The stimulants would be meth, dexedrine, amphetamines, cocaine. Those are methamphetamine, etc. All of those are classified under the
So do they give people a kind of happy, excited feeling, or what would be, how would I recognize if I saw someone that I knew using a stimulant or one of these, how other than maybe being
So
agitated?
let me also answer
or-
that in a little more detail.
Okay.
So there is substance intoxication, and there is substance withdrawal, and there is syndromes caused by the substance. So let me start by the third one.
Okay.
Any syndrome that can be caused by stimulant, you can see. You could see someone who looks manic. I don't know whether, common definition of mania is hyperverbal, hypervigilant, hypersexual, outgoing, on a high, essentially. And they might not be bipolar. So if you look at somebody in the acute phase of intoxication, they might be making friends with everyone, making jokes, sometimes appropriately, sometimes inappropriately. So that's during the intoxication phase. If you see them with the withdrawal phase of a stimulant, they're a slug sitting in a corner, vegetating, feeling depressed, sweating profusely, having stomach cramps, feeling essentially miserable. So a lot of times one leads to the other. Because of the fear of withdrawal, people use more and more to stay up. And they need more to stay up, and that's what creates the vicious cycle. So you can see them in any phase. Any drug could be seen in the intoxication phase, and they vary, of course. If you have a sedative hypnotic, they might have an initial euphoria, and then they are tired and sleepy and yawning all the time.
So that would be more like heroin and
Sedative hypnotics will be tranquilizers, like
okay.
Valium,
I see.
Xanax, sleeping pills,
where does heroin fit into all-
opioids.
Okay.
So opioids is one of the issues of addiction, and it's been on the news a lot, from politicians and others. And it's truly an epidemic because opioids are getting more and more lethal. More people die from fentanyl overdoses, and fentanyl is 100 times more powerful than morphine. And it's widely available on the streets, unfortunately. And there's also indication that some of the centers where there is heavy addiction, there is a disproportionate increased distribution of those substances in the communities, in some of the small towns and rural areas. So it is an epidemic. And then there's the prescription opioids, which doctors, unfortunately, are prescribing a lot of opioids.
They're getting a lot of people addicted.
Well, they are contributing to the addiction problem. In other words, let me kind of backtrack, being a physician. 15 years ago, there was such emphasis on relief pain, relief pain, relief pain. And a lot of doctors went through good training, but really didn't have enough training on substance use disorders. So they ended up very generously prescribing opioids. And we all know that it's very quick that people develop tolerance to opioids. And the 10 days after surgery become 6 years of opioid use.
And then they might tend to go to heroin then, huh?
There you go. And then with the drought on getting it from their doctor, after a while they catch on and they say, hey, no more. They go to the street and they get into heroin. And we see that revolving door.
I wanted to go back to the stimulants just a little bit. Now, is Sudafed, I know it's a medicine, but people seem to get kind of way up there and high on when they take Sudafeds.
Pseudoephedrine is a decongestant that is very effective. But now, if you go to a pharmacy, it's behind the shelf.
Right.
The pharmacist has to get an ID. It can make you feel hyper-aroused, but more important, a lot of the manufacturer of street drugs use it as a base for stimulants. They crush it and they create a meth type of product from it. So it's highly in demand for the wrong hands to create bad drugs out of it. In controlled settings, pseudoephedrine is very helpful for congestion. But now, because it's widely available, they have to keep an eye on it and control.
I can't imagine why anyone would want to take a hallucinogenic, but I guess people do. What are they then?
So phencyclidine, PCP, LSD, mushrooms, there are substances that create perceptual changes, and which means hallucinations, either visual or auditory hallucinations, and they work on the same reward center of the brain. So a lot of times people do them because they're addicted, but sometimes people are addicted to the changes they experience. You know, it's like going to a science fiction movie, but experiencing every minute of your life. They sit there creating all kinds of images. It's scary. You see people having conversations with people that don't exist.
How accessible are those drugs then?
Unfortunately, very accessible. Our market, street, black market and otherwise, is filled with hallucinogens and opioids, and unfortunately, and they're penetrating into, it used to be high schools only, but the scary part from a public health point of view, even middle schools are getting some, distribution of those. So a lot of these people are vulnerable to being swayed in that direction.
The inhalants are very easy for children to get a hold of.
That's the one.
Tell us about
Yeah,
some
that's
of
the one I missed earlier. Remember, that's the, thank you for reminding me. Inhalant is the other area of substance abuse. And they can inhale hydrocarbon products, and they get high from them. It could be glue, it could be other soluble chemicals that are used in cleansing, and people discover they can get high from it, and it's widely available. So you have to watch for that too, because who doesn't use detergents or hydrogen products?
Fingernail polish remover.
Absolutely.
So we need to watch our children, don't we?
I think we need to be educated and informed and aware that these things are available. With the internet, people have had information available too. So I don't want parents to be paranoid and suspicious. I just want them to be aware they have to be proactive and making sure their kids are doing the right things and they're not on the wrong website trying to get bad things. Because there's some bad things and bad people out there. But I don't want people to say, hey, we can't raise kids anymore because it's a dangerous society. Just be objective and aware.
I wanted to talk about alcoholism because it seems like when people overconsume, they have different symptoms. Some people become, very happy and loving, and others become sad, and then some become antagonistic. It seems like to me that alcohol produces different effects in different people. Is that the case with the hard drugs too? That say morphine might affect one person one way and somebody else another way?
The answer is yes, but let me talk about the alcohol, because that's really still one of the biggest issues of abuse in this country and in the world, because it's widely available. So to answer your first question, do people react differently? Yes. There are different phases. Again, the same model. We look at intoxication, we look at withdrawal, and we look at alcohol-induced syndromes. The intoxication phase, you can have people euphoric and comfortable. One of the commonest reasons people drink in social setting is because it acts as a social lubricant. It removes anxiety, makes people feel a little more comfortable, gregarious, etc. So people can get used to that effect. But there also could be the negative side. You have some mean, angry alcoholics, or their phases. If you go through withdrawal, it's a miserable feeling. And alcohol can cause all kinds of psychiatric syndromes. It can cause psychosis. It can cause hallucination, can worsen depression, can cause anxiety and panic. So alcohol affects people in different ways. And I'm talking about the other side of it is, I'm going to get back to your earlier question. Do people react differently? Absolutely. There is more and more evidence now that if you have inherited a gene for alcohol abuse syndromes, you're going to be particularly susceptible to dysfunctional reaction to alcohol. In other words, you might have what's called pathological intoxication with 1 or 2 drinks, which is not a whole amount for an average person, but they might develop syndromes sooner. You also can develop abuse and addiction. There are some people who inherited the alcohol dependency gene who cannot be social drinkers. You start 1 drink, too many. And AA and other 12-step systems will tell you, once an alcoholic, always an alcoholic, because some people are at a risk all the time of abusing alcohol or other substances.
Well, then there's nicotine, which is not as mind-bending, but it is still addictive. And you want to tell us a little bit about that?
Well, yeah, nicotine addiction continues to be a public health problem in the world. Maybe less so in California, but it's still a big issue. And it's interesting, when I travel east, you see more and more smokers. And there's also other forms of nicotine. There is chewing tobacco, there is sniffing, there is vapes, vaporized. They're all potentially addictive. And nicotine intoxication is not really a public health hazard, but it's attractive because a lot of people feel relaxed when they smoke, or mellow and so on, and that's one of the hardest things to quit is nicotine.
All of these things, like the tobacco, the alcohol, the various substances, the stimulants and everything else, are all relating to the same reward center in the brain. Is that correct? They're all coming in to that one center. So if somebody has a gene for alcoholism, rewards or whatever, and addictions, then they would be more apt to become addicted to these other drugs.
Correct.
Opioids,
and there's a lot of cross-addiction
so.
And combined addictions.
Well, that's what I wanted to ask you now, because you mentioned earlier the dual diagnosis of the mental illness and the substance addictions. Well, I think, people who are accustomed, people with mental problems are accustomed to taking all these medications to help their mind or their moods or whatever. Why wouldn't they want to try? And they're not that successful, a lot of those medicines. So why wouldn't they consider, well, maybe I'll try this. Maybe that'll relax. Maybe heroin will help or morphine or something would help where my current drugs aren't working so well. So
Well, I
does
think
that happen?
you touched on the vulnerability side. But let me also be clear on the record that a lot of the psychiatric medication interventions are not habit forming and do not go to the reward circuits in the brain.
But they don't always help entirely.
That's the issue. In a
Right,
previous program, I talked about the success rates or lack of with depression and anxiety. That's why we need proactive and more effective treatments for those conditions. Because if you have a depressed individual and you've given them 10 antidepressants and none of them has really worked, and they discover they can get rewards from heroin or alcohol or cannabis, obviously they're going to go in that direction because their primary issue was not resolved. That's why in our program we emphasize very much looking at both sides simultaneously. If there is a depression underneath or bipolar or anxiety or ADHD, appropriate intervention in an evidence-based way would lessen the likelihood of going to the streets for finding a quick fix solution that makes everything worse.
Now, what would happen if they remain on the drugs their doctor has given them, but they're taking these other things as well? Would that be a
Well, then you have
catastrophic
serious,
for them?
potentially serious medical consequences. We worry about liver because everything you consume is going to be metabolized through the body. So the liver, the circulation, the kidneys. So you could actually be accelerating liver damage, liver cirrhosis, your brain. I mean, we know that chronic alcohol use in heavy amounts, you could have brain damage. You can have a dementia type presentation. So when you combine, I always tell some of my patients who are tending to use street drugs, listen, your drug or my drug, because if you use both, they're going to compete for the same receptors in the brain, which can create negative effects, can interfere with the binding sites, can create more peripheral side effects. So absolutely, there is potential for serious complications.
Well, now, there are some anti-craving drugs. Would you tell us about those?
Yes, so the field of addiction medicine is really changed in a positive way dramatically. So now the research shows that if you're an alcoholic, for example, so let me backtrack. With opioids, we treat opioids. Methadone has been around for a long time. And then we have a newer version of an opioid agonist called buprenorphine, or commercially available as Suboxone, Subutex. The research in alcoholics shows that those who get addicted to alcohol are releasing an opioid-like substance in the brain. So they discovered that the blockage of that release can decrease cravings. So there is a medicine called naltrexone, which is used. It's available in different commercial names. Revia, which is oral. It's available in injectable form once a month, called Vivitrol. For someone who's not motivated, the doctor can give them a shot once a month. And there is one called acamprosate, that's the generic name, or Camprol, that tackles a different mechanism for cravings. And there are experiments on other medications that will be available. So that's really made a big difference. Let me add a footnote, though. Very much when you're treating addiction, you don't treat with one solution and one drug. Sometimes you need to combine behavioral interventions, support groups, pharmacology, and fixing the underlying problem. So the more multi-pronged approach, the more successful you'll be.
Now, people with this dual diagnosis, can they still take these things along with their psych medicines?
Absolutely, absolutely correct. Actually, that's one of the reasons I did a fellowship in substance abuse, because sometimes I find people who are chronically into pain medication, let's say, and you treat it effectively with the buprenorphine, it facilitates the treatment for the depression much more effectively. So we're really excited to see that we've changed lives by addressing both sides simultaneously.
Okay, and then how about the TMS?
Well, transcranial magnetic stimulation is a non-invasive way to treat the brain. And we found out that there is especially what's called deep TMS, targets the craving center of the brain. We've had some people who have had refractory addiction issues and cravings, where combined TMS, they have depression and they have cravings, And now they are successful in their 12-step program because the craving is gone because of the deep TMS. So it's stimulating non-invasively the areas of the brain that lack dopamine by releasing dopamine, and they feel motivated to do things. So it is a new generation of treatment tools we have.
What about ketamine? Does that fit into there anywhere?
Ketamine is now looking it's not yet FDA approved, but it looks very, very good. In our clinic, we have a ketamine program. We've had great success with depression treatment. But you have to be careful, because if somebody is actively substance abusing, they might not be a good ketamine candidate, because ketamine has been abused among drug addicts. But if they have depression and addiction, then fixing the depression with ketamine, if it doesn't respond to medication, psychotherapy, or TMS, can make a big difference. So individualized treatment, where it's at. We also have personalized medicine now. We have genetic testing that we can take a DNA sample. You can come to my clinic. I can tell you whether the Prozac is the right drug or the Zoloft is the right drug, or whichever, based on your genetic profile.
Can you tell if the percentage of dopamine that a person has, if they have too much or not enough? Can you do that in any test?
Not on a reliable. There are some peripheral tests for dopamine, serotonin, and norepinephrine. Unfortunately, they don't measure what's inside the brain because there's a barrier called blood-brain barrier, however, which blocks the entry. So I have people coming in with a blood test for dopamine, doesn't mean much. However, there is functional imaging tests of the brain called functional MRI or SPECT scans that can show different uptake in some of the depleted areas. It's not yet commercially available or reliable because it's expensive, but there's promise that that might be a good tool in the coming decade.